Welcome to my channel Pediatrics and Life Tips. Today I will talk about congenital syphilis. Congenital syphilis is caused by an organism Treponema pallidum. It belongs to spirochetes family and is a tightly spiral motile organism with finely tapered ends. It stains poorly and is not detected by conventional light microscopy, and it can't be cultured. Congenital syphilis mostly result from transplacental or vertical transmission of spirochete from the mother to fetus. Women with untreated primary and secondary syphilis can transmit the disease to their fetus at any time during pregnancy, and this vertical transmission rate is more than 90%. Fetal or perinatal death occur in about 40% cases, and premature delivery can also occur. Newborns can also be infected at delivery by contact with an active genital lesion. Now I will discuss the clinical features. Most infants are asymptomatic at birth and symptoms develop in first 2 months of life. It is generally divided into 2 stages, early sign and late signs. Early signs appear in first 2 years of life and late signs appear gradually in first 2 decades after second year of life. First I will discuss the early signs of congenital syphilis. In this, multiple organ involvement is present and the signs are variable. However, Hepatosplenomegaly is present in all cases. There is also jaundice and generalized lymphadenopathy. This lymphadenopathy resolves spontaneously, although shorty nodes can persist. There is an erythematous maculopapular or vesiculobullous rash, which is followed by a desquamation of hands and feet. Mucus patches are also characteristics. There is also persistent rhinitis, which is known as snuffles. Condylomatous lesions are also present. Now all these moist lesions contain abundant spirochetes and the infant is infectious until 24 hours of therapy. In early congenital syphilis, Coombs negative hemolytic anemia is a characteristic feature. However, non-immune hydrops can also occur. Thrombocytopenia is also present and it is due to the trapping of platelets in the enlarged spleen, and this results in bleeding episodes. Bone involvement is common in congenital syphilis. Early radiological findings include Wimberger lines. These are metaphyseal demineralization of the medial aspect of the proximal tibia. There may be osteochondritis, which is present in the form of punctate lucences or destructive lesion at the wrist, elbows, ankles, and knees. There may be periostitis of the long bones and the skull. Now, osteochondritis is usually painful and the child refuses to move the limbs. This is known as pseudoparalysis of Barrett. Now, there may be congenital neurosyphilis, but it is often asymptomatic in the neonatal period. There is also failure to thrive, and there may be nephritis or nephrotic syndrome or hypertension. Now, less common features of early congenital syphilis include gastroenteritis, peritonitis, pancreatitis, pneumonia, chorioretinitis or glaucoma, and testicular masses. Now I will discuss the late signs of congenital syphilis. In the skeletal changes are prominent, and these are caused by recurrent or persistent periostitis and associated thickening of the bone. These include Olympian brow, which is a prominent forehead. Clavicular sign or hygumenikia sign is a thickened sternoclavicular third of clavicle. There is also scaphoid scapula, that is a convexity along the medial border. Other skeletal changes in late congenital syphilis include Saber shins. In this, there is anterior bowing of mid-portion of tibia, and it is also due to periostitis. Now, Clutton joint is a hypersensitivity phenomena. It is a painless joint swelling, usually due to synovitis, and usually knees are involved. It may be unilateral or bilateral, and there is spontaneous remission after several weeks. In congenital syphilis, saddle nose is a characteristic feature. It is the depression of nasal root and is caused by syphilitic rhinitis, which destroy the adjacent bone and cartilage. It may be associated with a perforated nasal septum. Now, Rhagades are also characteristic of congenital syphilis. These are spoke-like pattern linear scars which extend around the mouth, anus, and genitalia. Dental abnormalities are also common, and these are due to abnormal enamel formation. Hutchison's teeth are peg-shaped upper central incisors, and in this there is a notch along the biting surface. Mulberry molars are abnormal first lower molars, and they have small biting surface and excessive number of cusps. Ocular manifestations are also common in congenital syphilis. The most common is the interstitial keratitis, which may be unilateral or bilateral. This causes intense photophobia and lacrimation. Corneal opacification and complete blindness can occur. There may be choroiditis, retinitis, and optic atrophy. Now, some rare manifestations of late congenital syphilis. These include juvenile paresis. It is a latent meningovascular infection which can lead to behavior changes, focal seizures, or loss of intellectual function. There may be juvenile tabes. It is a spinal cord or cardiovascular involvement with aortitis. There may be 8-nerve involvement, which may be unilateral or bilateral. This can lead to vertigo and deafness. Other rare manifestations include soft tissue gummas and paroxysmal cold hemoglobinuria. Now, Hutchison's triad in late congenital syphilis include 3 features. First is the Hutchison teeth, then interstitial keratitis, and third is the 8-nerve deafness. Now, I will discuss the diagnosis of congenital syphilis. First is the serological testing. This includes non-treponemal reagin serological test. In these 2 tests are done. These are rapid plasma reagin test and venereal disease research laboratory test. These tests measure non-specific antibodies against the phospholipid antigen on treponemal surface that cross-react with host cell antigen. These tests are useful for routine screening and are equally sensitive, inexpensive, simple, and rapid. And these tests correlate with disease activity. In serologic testing, second is the Treponema specific test. These include Treponema pallidum immobilization test, fluorescent Treponema antibody absorption test, Treponema pallidum particle agglutination test, and enzyme immune assay. These tests measure antibodies which are specific for Treponema pallidum, and these tests are used to confirm a positive non-treponemal reagin test. However, these tests do not correlate with disease activity. Now, second is the direct examination for spirochetes. In this, dark field microscopy or direct fluorescent antibody testing is done. Spirochetes are visualized in scraping exudate serous transudate from moist lesion or tissue. This provides a definite diagnosis when it is positive. Now, other ancillary testing shows anemia, thrombocytopenia, leukopenia or leukocytosis. Monocytosis is also common. Coombs negative hemolytic anemia is characteristic. There may be elevated alkaline phosphatase, aspartate aminotransferase, and alanine aminotransferase levels. Serum bilirubin is moderately elevated. Prothrombin time may also be increased. Cerebrospinal fluid examination may reveal pleocytosis and increased protein and a positive VDRL test. Urine examination may reveal hematuria or proteinuria. Chest X-ray may show syphilitic pneumonia, in which there are fluffy diffuse infiltrates. This is also known as pneumonia alba. Now, long bone X-ray and joint X-ray should be done in all cases in order to reveal specific syphilitic findings. Ophthalmic examination is also important, and auditory brainstem response should also be assessed. Now, I will discuss the treatment of congenital syphilis. In newborn, aqueous crystalline penicillin G is given if congenital syphilis is proved or is highly suspected. Dose is 100,000 to 150,000 units per kilogram per day intravenously every 8 to 12 hours to complete a 10 to 14-day course. Procaine penicillin G is given intramuscularly in a dose of 50,000 units per kg as an alternative. Now, in a newborn, congenital infection is suspected with the following: physical or radiographic evidence of active disease, serum quantitative non-treponemal titer at least 4 times greater than the maternal titer, reactive CSF VDRL test result or abnormal CSF cell count or protein levels, positive immunoglobulin M fluorescent treponemal antibody absorption test findings, or positive dark field microscopic findings or positive findings when staining for treponemas in placenta or umbilical cord. Now, treatment of congenital syphilis in infants more than 4 weeks old and children include aqueous crystalline penicillin G 2 lakh to 3 lakh units per kilogram per day intravenously divided every 6 hours for 10 to 14 days. During treatment, Jarisch-Herxheimer reaction can occur. It is an acute systemic febrile reaction due to massive release of endotoxin-like antigens during spirochete lysis. It occurs in 15 to 20% of patients treated with penicillin. However, it is not an indication for discontinuing penicillin therapy. Now, the long-term monitoring recommendations in the case of congenital syphilis include follow-up should be done at age 1 month, 2 months, 4 months, 6 months, and then at 12 months. Obtain non-treponemal titers at age 3 months, 6 months, and 12 months after conclusion of treatment. Non-treponemal antibody titers should decline by age 3 months and should be non-reactive by age 6 months. Now, consider retreatment for patients with persistently stable titers, including low titers. Infants who are treated for congenital neurosyphilis should undergo repeat clinical evaluation and CSF examination at 6-month intervals until their CSF examination result is normal. A positive CSF VDRL test at age 6 months is an indication for retreatment. Thanks for watching this video. Please like, share and subscribe to my YouTube channel.